There we go. Okay, again, welcome to this session. I'm planning to talk to you for about half an hour. I don't know exactly how long this is going to take. This is new for us as well. We normally have these kinds of events in a lecture hall, but now I'm doing it from my home with a purple background. What am I going to do? I'm going to talk about HEPL and health economics, which are two specializations of the same master's program. What are they about? What's the difference between them and the similarities, because there are more similarities than differences actually. I'm going to discuss two of the most important courses in the program, two courses that everybody follows, the organization, what you can do afterwards, after you finished HEPL or health economics, how you can get in, and then we'll probably have 10 or 15 minutes. Don't know exactly for your questions. Okay, first of all, there are two programs here. HEPL, Health Economics Policy and Law, it's clearly multidisciplinary, whereas health economics focuses on health economics. It's that simple. So that's the difference between the two, but they are both about improving healthcare. We educate people who want to contribute to improving healthcare, and particularly health policy and health systems, not so much hospital organization. That is the field for healthcare management. We want you to learn things, to remember things, to know things, also to be able to analyze developments and problems in healthcare systems. Before I continue, I think I should explain to you what I mean by healthcare systems. A healthcare system, a health system in our terminology, does not mean a group of hospitals. By health systems, I mean the way healthcare is provided and paid in a country. How are decisions made? For instance, in the Netherlands, we have a system of managed competition. We have several health insurers to choose from. Everybody has to be insured, and there is some limited form of competition between hospitals. There are also countries where all healthcare is government-based, or much of it, like the United Kingdom. All the hospitals are more or less owned by the government, and you do not need health insurance to be treated there. Every country has a different systems. There are some main types, but even they are different internally. In the United States is a system that is more or less like the Dutch system. At least Obamacare has elements that were copied from the Dutch system, but there is a lot more market in there than we have here, for instance. So that's what we mean by health system. But it's more than insurance. It's also about ownership. Are there hospitals? Are they companies, or are they not-for-profit organizations? Do you have health insurance, or do you have healthcare that is freely provided? You can pay doctors by the amount of work that they do, by the amount of interventions that they perform, or you can just give them a salary. And that means that there are different incentives for them. Another important element for the healthcare system is whether people have equal access, or that you can buy more access if you have more money. That is what we mean by health systems. Health systems are expensive. They are very expensive in most of the world, especially in the Western world. This graph shows you how much money Western countries, OECD members, mostly Western countries, spend on healthcare as a proportion of their national economies. So on average, it's about 9, 10, 11%, with an outlier on the left of the graph. The United States with close to 18, 19, 20%. These percentages are different in different calculations because you can use different definitions, but the fact that we spend a lot of healthcare is clear from all calculations, and that the US is an outlier is clear as well. So we spend a lot of money, but what do we get in return? We are buying health. This graph shows the decline in mortality rate, so the proportion of people who die every year. Those proportions have declined very much since 1995. And a lot of that is really due to better and more healthcare. So we are buying health and we are buying time. For HEPL, for health economics, the central question here is, okay, we are spending money, we are getting something in return, but could we do better? Could we get more value for our money? Or could we perhaps pay less money and get the same health? Actually, this is a slide that we show at the beginning of every course in the program. These 7 questions are addressed in all courses. The challenges for health policy makers, not only higher expenses, but also perhaps problems with access or waiting lists, for instance. What can they do about it? How can science of economics help to explain what's going on and what solutions may be? We're looking at healthcare through an economic lens all of the time. And we also add policy science to know how policy is shaped. Why don't all countries do the same things if economists are so brilliant at finding the solutions? Or aren't they as brilliant as we think? There are also legal limitations. The government cannot just do anything it wants to do. There are human rights, there are international treaties, there's international law that all limits the freedom for governments to act. And of course, we don't only want you to know things and to understand things, we also want you to be able to assess research done by others and do your own research in the form of a thesis. This is an overall view of the questions that we deal with in the program. More specifically, this is the curriculum. You see the HEPL curriculum and the health economics curriculum, and everything that is in the same color is the same thing. So it's clear from the beginning that a lot in the programs is the same, everything in green and red. In the first semester, if you choose HEPL, you get these 6 obligatory courses. Everybody does them, and for health economics, these courses are a little bit different. In the second semester, then you do have choice. You have to choose either 2 or 3 elective courses, and you write your thesis. It's important to note, before I forget, that the health economics program is something that Erasmus School of Health Policy and Management does together with Erasmus School of Economics. It's a program, it's a joint venture, as we like to say, of Erasmus School of Economics and ESHPM. So everybody has 6 compulsory courses in the first semester, and I'm going to discuss a few of them, actually 2, the ones that are printed in bold here. Economics and Financing of Healthcare Systems. That's a course that you start with in September, and Economics of Health and Health Care. You see we have 6 blocks over the course of the entire year. That means that all blocks are 6 to 7 weeks. You follow 2 courses at the same time, and then you start with the next block of 2 courses. This is maybe the HEPLest HEPL course that we have, Economics and Financing of Healthcare Systems. It's obligatory for HEPL students and for health economics students, and it describes the 3 or 4 types of healthcare systems that we distinguish. And we look at these systems mainly from economic perspective, but also from the perspective of comparative policy science. Here comes my first statement, and I'd like to know whether you agree with this. Healthcare expenditure in the recent decades, that is a problem and it should grow less. If you agree with this statement, please raise your hand now. I'll give you a few seconds to raise your hand. I see people doing it. The number is going up. Okay, we have 23 votes out of 61, including Isabel and me, who think that expenditure should grow less. Okay, lower your hand again. Now I'd like to know people who do not agree with this statement, who think that it's okay for healthcare expenditure to keep growing at the pace it's growing now. We can afford this, it's worth it. Who agrees with that statement? Of course, this is not a scientific fact. This is a political opinion, actually, and people may have different opinions about this statement. Okay, I see that a sizable proportion of people raised their hand because they did not agree with this statement, but actually the people who think that it should grow less are in a clear majority here, which is fine. But if you want, you can lower your hands now if you like, but if you want healthcare expenditure to grow less, then you should know why it is growing so fast. And there are lots of reasons for that. And some of them can be influenced by policymakers and some of them can't. So it's clear that it's very difficult to make healthcare expenditure grow slower. One reason why it goes up and up and up is the advancement of medical science and technology. More and more treatments, machines, drugs are available, and we value health, so we want them. It's difficult for a politician or a policymaker to say, well, these drugs exist, but you cannot have them because they are expensive. So that drives up costs, but it also brings extra health, we hope. Aging of the population. Older people have more medical problems, they have to be addressed. And actually, aging of the population is a success of healthcare. Fewer people die later because they get better healthcare, also means that they get more chronic diseases. Some time ago, people might die at 60 when they had a heart attack. If we prevent this heart attack or treat it better, then people can live to be 80 or 90 years old with the risk of getting dementia or lung disease or cancer or other problems. They're actually a success of medical science, but it brings extra costs. We get richer and richer, at least most of the time. And that also means that we attach more value to health and health care. So we want to spend more money. Almost cost disease, that is a principle from economics. It means that when there are sectors in the economy that become more productive because they use more ICT, for instance, or other forms of automation, the workers in these factories become more productive, their salaries can go up, and the salaries in other sectors have to go up as well, because otherwise they wouldn't be able to compete on the job market. And individual production for nurses and doctors doesn't go up as quickly. That means if we want to have the same amount of care we wanted 10 years ago, we have to pay more. And then, last point I'm going to discuss, there are incentives for healthcare providers and patients, and they may work in the wrong direction. If you pay a doctor or any organization for the production that it provides, they are going to produce more. If you want a doctor to work hard, you can pay them for every patient that they see, and you know that they are going to see more patients. If healthcare is free at the point of use for patients, people are going to use more of it. So these are all reasons why healthcare expenditures go up and up. And I hope it's clear to you that this means that it's difficult to do something about it. But there are solutions, and they are discussed in HEPL Healthcare. So that is the first course and the kind of discussions we have there. The second course that I'm presenting to you is called Economics of Health and Healthcare. It's an obligatory course in block 2, starting mid-October. And it's not about typology or the economic incentives that healthcare systems have. It's about their performance. For instance, equity and efficiency. Those are the most important concepts. And with equity, we mean does everybody pay equally, or do richer people pay more than poorer people, or the other way around? And do we all have the same access to healthcare, or is it easier to get into a hospital when you have more money? Efficiency is the other concept, is about value for money. If you spend a certain amount of health as a country on your healthcare system, what do you get out of it? And can we compare it to other countries that spend the same amount of money? Are they buying more health or less? I have a statement about this course as well. Do you think this is true? Rich people benefit more from healthcare than poorer people. And I'm talking about the Western world here. It's a bit difficult to make these sweeping statements about the entire world. So raise your hand again if you think that rich people do benefit more from healthcare than poorer people in Europe, North America, Australia, East Asia, for instance. See the number of hands are going up, still rising. Okay, it's stuck at 38 now. That means that a clear majority of you thinks that this is true. Rich people benefit more from healthcare than poorer people. To find out, you can lower your hand again. To find out, let's look at a graph that's actually used in this course, Economics of Health and Healthcare. This is about the relationship between healthcare expenditure on the x-axis and mortality on the y-axis. So more mortality is bad, less mortality is better. So if you are lower on this graph, you're in a better position. So these are data from a lot of countries over a lot of years. What do we see here? We see, for instance, that there is more mortality among men in green than among women in red. And there is more mortality among people with lower education. And that is true for all levels of healthcare expenditure. What we also see is that all groups benefit from higher expenditure on healthcare. All the curves are sloping downward, which means that higher expenditure goes with lower mortality. So everybody benefits. But who benefits the most? Actually, here, the men and people with a low education see their mortality go down the most as healthcare expenditure increases. So the people who have most to gain from healthcare actually gain the most. So compared to the beginning with lower healthcare expenditure, this healthcare actually increases equity in health outcomes. So the statement that richer people benefit more from healthcare than poorer people is not true overall in the Western world. And that is because poorer people in general have the most to gain, and healthcare systems in Europe, even in North America, are pretty open to most people. So this might be a surprising, also an optimistic result. This is a way of assessing the performance of healthcare systems, the equity. The next slide, the next graph is about efficiency. Again, on the x-axis, we have the health spending per capita now. It goes up from almost nothing to $9,000 per person per year. And on the y-axis, we see life expectancy. So here, a higher life expectancy is better. So countries want to be at the top of the graph, not at the bottom. Again, we see the relationship. More healthcare spending goes along with higher life expectancy. But there is a limit. This relationship has a curved shape, and it seems to be difficult for countries to get really higher than the curve. More money means more life expectancy, but adding more money leads to smaller additional results than before. If you follow the curve from $2,000 to $4,000, life expectancy goes up by, 2.5 years. If you go from 4,000 to 6,000, it's only 2 years. We also see here that there are a few countries that are outperforming the others and countries that are underperforming. For instance, we see the USA spending most money of everybody, totally on the right, but it's clearly below the curve. Their life expectancy is compared to Chile or the Czech Republic on the left, who are spending much, much, much less. And another strong performer is Russia, which doesn't spend that much money, but even with that amount, they would be expected to get better results in the league of Brazil and Mexico or Poland. So these are the two elements that we address in this course: efficiency, is this graph, and equity in the previous one. Back to the curriculum overview. I discussed the two courses in bold. There are more courses, of course. I have no time now to go into them, but you can see descriptions of them on our website. I have to point out an important difference between HEPL and health economics, because I stressed that lots of it was similar, but the differences are in block 3, especially. HEPL students have a legal course, international health law, which is about human rights and international treaties, and a policy science course called comparative health policy. And in the same block 3, health economics students follow courses that are very analytical and focused on econometrics. After this obligatory phase in the first semester, you get to choose your electives. We have a list of 9 for HEPL and 7, all the courses in black, for health economics. And this allows you to focus your studies on a certain field. For instance, the developing world, or if you want to be policy oriented, we have courses for that as well. If you want to get even better at analyzing developments or the value of healthcare innovations, we have courses for that. We have course devoted to the pharmaceutical industry, and it's totally up to you. All combinations are possible. That makes it also possible for HEPL students to choose a very much economically oriented package of in their studies, especially when they combine this with a thesis topic that's also economic. But you might also choose for the less economic courses here and write your thesis on something completely different, non-economic. So what the difference is between HEPL and health economics also depends on the choices you as a HEPL student make. So you have these 9 or 7 courses to choose from, and that completes the description of that curriculum. What does your week look like? Well, normally, outside of the Corona situation, it would be like this. We have lectures with big groups in big lecture halls with normally 100 to 200 students in the room. Work group meetings in smaller groups, obviously. PC labs. We will have some videos for you to prepare things online. You as students would have your own presentations of research you did, papers you read. You're going to read a lot of literature, write essays, do exams in the exam hall, and write your master's thesis. That goes for HEPL and for health economics. Something else that they have in common is that all of our teachers are also publishers, researchers, and most of them are really prominent in their fields, and they contribute to the advances in health economics and health policy, health law, etc. We have guest lecturers, people who might be policymakers or people from the pharmaceutical industry, for instance. And it's important to stress that everything we do is about theory. We use theory, we use formulas, we use graphs, but it's all about the real world. It's about the real healthcare sector. It's about real health systems and it's about real patients and doctors. It's very relevant, and it's not made up, and it's not purely theoretical. We start in September. Expect to spend 40 hours per week on your studies until next summer. You have 2 weeks of Christmas. Normally you would be 10 or you would be at university for 10 or 16 hours a week for lectures, workgroup meetings, PC labs, etc. If you want, you can do this part-time, but we do not facilitate it. So it's possible that if you follow only one course, in block 1, it will be on Mondays and Tuesdays, and in block 2, your one course would be on Fridays and Thursdays, for instance. So we don't encourage that, and we assume that students are available from Monday to Friday. And we assume this even in this Corona crisis. We don't know exactly how this is going to work out, what decisions we have to take over the next year. But we've established the principle that we want to make it possible for everybody to study HEPL and health economics, whatever the developments are. We acknowledge that some students, especially when they're from abroad, they may be unable to travel to Rotterdam, especially at the beginning of the academic year. We don't know when we will be able to have physical meetings on a large scale, like the lectures. Maybe not even smaller meetings. That's all not clear now. So we're already preparing to make it possible for everybody to follow all courses in block 1. There are 3 of them online. So we're going to broadcast the lectures through Canvas, and recordings of the videos will be made available. And instead of maybe as an addition to the physical meetings, we will organize video conferencing in Zoom, like this meeting, for the smaller group meetings, maybe for everybody and maybe only for students who are abroad. We haven't made these decisions yet, and we don't know what's going to happen in block 2, but the principle stands. If you are a HEPL student, we will make it possible for you to study online if the circumstances make that necessary, and if things return to normal, or more or less to normal, we will start organizing things on the university campus again. We also hope that in September or October of next year, we will see you on this stage in the aula, our biggest hall at the university, when you graduate, when you get your diploma, your hats. It is supposed to be a very festive occasion. It's one of the best days of the year for me. We have no idea whether we're going to organize this for the current year. Hopefully we can do it for you next year. So that's graduation. After that, what can you do? Our alumni actually end up in lots of places, many of them in government, in many countries, international organizations like the World Health Organization, the World Bank. Some people work at universities, in the pharmaceutical industry. That's an important job market for our graduates. Consultancy firms who advise governments or pharmaceutical companies, healthcare insurers or other organizations in the healthcare sector, for instance, lobby institutions. We have an ex-HEPL student who is in the European Parliament, a liberal from Hungary, and she actually credits HEPL with getting her there. She uses it in her Twitter handle. Her name is Kathleen Czech, and she spoke at our graduation last year. We acknowledge that most of you will not be in European Parliament, but that's also an opportunity or a possibility, apparently. If you want to be a hospital manager, you may choose healthcare management. That would probably be more suitable to you than HEPL. That's going to be in a presentation session after this one. But if you want to be a health minister in government, then HEPL would probably be the right choice. Of course, that's not what you start out with. It's not a starting job, but that is where students may end up. At least we have the ambition of being that influential. I was going to show you, I see now that it's technically impossible. I was going to show you the LinkedIn profiles of a few of our graduates. They're actually all in the fields that I just showed you: pharmaceutical industry, government, etc. If you are interested after hearing what I told you and maybe seeing more information online, and you want to submit your admissions, this is what you should keep in mind. We accept students with a Dutch bachelor's or master's degree in health policy and management, public health, economics, policy science, law, medicine, and pharmacy. If you have one of these, then you are guaranteed to be admitted. If you don't have this, you might still be admitted. We look at all applications individually, and we admit similar degrees like economics from a non-Dutch university, if it is similar in quality and its level. If you have a program that's not on this list, not even from a different country, then we can still try to find reasons to admit you. For instance, if you have sufficient background in economics, health economics, policy science, research methods, etc. So in all applications, we look for reasons to be able to admit you. So if you are not sure whether you can be admitted, just apply. It's not so much work. Apply through StudyLink, and we will let you know in a couple of weeks. In almost all cases, we have a decision within a month, but usually a little bit earlier than that. So if you don't know whether we can admit you, try. There are no costs involved, so you can just do it. If you have done a bachelor's or a master's study that is not in the Netherlands and not in an English-speaking country, we also ask you for proof of your proficiency in English. You can use a number of tests for that, and more detailed information about it is on the website. So in conclusion, if you are someone who wants to improve healthcare, health systems, health policy, you like economics, you're interested in policy, you want to find solutions using different perspectives, not just analyzing things. If you want to make up your own mind, think for yourselves instead of just following recipes and ideology, then we hope to see you in September for a solid base for your career in healthcare and health systems improvement. That is what I had to tell you. Now, if you want more information, you can go to the website, www.hepl.nl, with all detailed information. We have an email address for your individual questions, study information at eshpm.ur.nl. And we are still here. So if you have any questions, ask them on the chat function. Question: how many students apply every year? I don't know how many students apply, but I do know that about 160 started. That was HEPL and Health Economics combined in last September. So we expect more or less the same number of students this year. And the majority of them is HEPL students. It's about 100 HEPL and 60 health economics. It's difficult to say how many apply. I couldn't tell you what a proportion of successful applications is, for instance. If you, we don't have a limit to that. If you are, if your background is good enough to be admitted, you will be admitted. I hope that answers your question. Is there a lot of statistics in the HEPL Master? Yes, there is. Actually, we assume that you have a solid background in statistics. We don't test that beforehand, so that is your own responsibility. We start out with a course called Advanced Research Methods that also assumes that you have done some testing, some regression analysis, and that you have some basic ideas of what statistics are. That course is about an intuitive understanding about research and statistics. So we're not going to teach you new methods on top of what we assume that you already know. That might also be an occasion for you to brush up your statistics. And statistics are part of all courses, not testing how good you are at statistics, but you will have to read scientific literature in economics, which is full of it. Next question, is it possible or encouraged to follow both the HEPL and the Healthcare Management Master? It is not encouraged, definitely. Is it possible? It depends. We don't facilitate it. So it is likely that on Tuesday afternoon, you will be expected to be in one room for HEPL and in a different room for healthcare management. In addition, both programs assume that you are available for 40 hours a week. So doing both at the same time in 1 year is probably going to be too difficult, too much work. There are some people who combine HEPL with the part-time healthcare management program that make it a little bit easier, but would still involve a very heavy study load. Is it possible to arrange an internship or your own thesis? The program has a sort of an internship in combination with some of the theses. We are in contact with interesting organizations like the CPB, the Central Planning and Agency in the Netherlands, where you can do your thesis research as an intern. So that's not about work experience, that is about doing research in a different environment. So that is possible. It's also possible to arrange your own, come up with your own thesis topic. Actually, we encourage that. We have our own list with possibilities that you can choose from. But if you have a better idea, if you have your own idea, that's great, and we'll try to make it work for you. But you will have to follow the ESHBM thesis rules, obviously. You will have a supervisor from ESHBM, and you will have to comply to the standards. But students will have their own initiatives. That's something that we like very much. Can you apply for research placement internship at an organization or business during the thesis period? Yeah, that is what I answered. We provide a list of internships that you can apply for. Usually more people want that than we have places available. But in principle, it is possible as long as it's about writing your thesis there. Is there a day in the week where you don't have any lessons, where you don't have any classes and you don't have to come to the university? Usually we have one of those days, but not always. It's not something we can guarantee. But we try, in every block, we try to keep at least one day free of classes. Is the healthcare management presentation in the same Zoom meeting? If not, can you please give the Zoom ID and password?
I gave the Zoom ID and password, and I also answered the question from somebody who asked up until when they can apply for this master. So those both questions are answered in the chat.
Okay. Does the pre-master also offer the first semester online? First of all, I wasn't talking about the first semester as a whole. I was talking about the first block, because we can already foresee that it will be necessary to do so then. And the same principle goes for the pre-master. If it's only possible to do things online, then we will provide that probability. Next question, is there a possibility to go abroad within a master? Normally, there is. We have a cooperation with the University of Oslo during the elective phase. You can do your electives there, but I have no idea whether it will be possible to do so in the spring of 2021. Whether travel will be possible, well, whether Norway will allow you in, but normally there is a possibility. Lots of questions. Are all work groups obligatory throughout the year? No, most work groups are not obligatory, but we are organizing work groups more and more, or we are organizing courses more and more around the work groups. We are trying to present courses, not that you have lectures and you can do some practice in the work groups. It's mostly the other way around. The work groups is where you really learn, where you work, and the lectures are a preparation for the work group. So in most courses, work groups are not obligatory, but it is very important for your own learning to attend. Can you do your thesis abroad? We usually have a few thesis topics in South Africa. Yes. So in principle, it's possible. If you have your own arrangements to go abroad and do something there, that is allowed as well, as long as we can find a supervisor within ESHPM who is willing and able to assist you in writing your thesis. When do you have to apply for your master's next year? Can you apply for health economics and HEPL and then make choice later? You can apply now until the 1st of June. And of course, you can deregister as well. It is important, given that the first course of HEPL and health economics is already different, that you make a choice before you start. It's not something that you can do during the year. But if you want my advice, if you really like statistics, econometrics, if you would love to do that all day, then health economics is going to be great fun. And if you think statistics is nice sometimes, and you need it, but you like to do different things most of the time, then HEPL is probably better. And if you hate everything to do with statistics, then neither program is going to be very pleasant for you. Scrolling down. How would I'm not sure whether I'm going to answer this. How would I analyze the reaction of the Dutch government to COVID-19 from a HEPL perspective in a couple of sentences? Well, I have no appraisal for that reaction now, but the questions that you could ask is, who, from a HEPL perspective, is who are the people who are infected? Because there are people who are able to work from home in a relatively safe environment and people who have to go to work. Are there socio-economic differences in across people who are infected? Does everybody have the same access to treatment? Do people get poor because they are hurt by COVID-19? Do they lose their jobs? That might be different in different countries. So if it's about the availability of tests or the organization or the scaling up of intensive care units in hospital, that's not really a HEPL topic. But if we're talking about the access to healthcare and the financial consequences and so on, that's something that will definitely be discussed. Will the academic year start in September, regardless of the corona situation? Yes, it will, and we will make it possible for you to attend classes, whether it is in Rotterdam or from a different place. We will start. What is special about studying in Rotterdam compared to other universities in the Netherlands? I think you mean what's special about HEPL or health economics. That's basically that they don't have this anywhere else in the Netherlands. Of course, there are programs that do some health economics, but we are fully focused on health economics in a health economic specialization, and we do much more economics in HEPL than there are in comparable programs, for instance, in Amsterdam or Maastricht. So that is the main difference, I think. Is it easy to go from pre-master to the master's program? What are the experiences of students? Well, actually, the pre-master program is designed to make it possible to enter HEPL master's program. And it is really possible. And students from the pre-master usually fare well with HEPL. So that is not something to worry about. I read on the EUR website that Dutch students are able to apply until the 31st of July. We want to, is that true? We want to encourage you to apply as soon as possible. If you apply soon, then we can let you know soon whether you are admissible or not. If we can, we will process all the applications until the beginning of the year, but it will be more difficult for us and for you. So if you can, please send your admissions or send your application before the start of June. Do you need a background in economics to study health economics? Yes and no. Well, you can be admitted without a bachelor in economics, but you have to realize that this is really about economics. So you will probably have to work harder than other people, and you might be less certain that this is really something that you want to do. But the list of backgrounds that are admissible for HEPL and health economics is actually the same list. So if you did health sciences somewhere, we will admit you to health economics, but it's a little bit, it's your own responsibility. If you have oriented yourself well and you read something about economics and about econometrics and you think, well, I really like this, then you should be able to do it. I have answered all the questions that were sent through chat. Is there anything else very urgent? If not, and you come up with something that you would like to ask us later, please use the email address or go to the website, studyinformation@eshbm.eur.nl. There's a lot of information on the website. And if there are no further questions, then I'd like to end this meeting here. I'd like to thank you all for being here, for your attendance, for your attention, and for your questions. And I really hope to see lots of you in person in September. One question of, is it possible to do the pre-master if you did an HBO study? Yes, it is possible. The pre-master is open for people who did HBO, nursing or physiotherapy or something related to healthcare, and the exact conditions to be admitted to that are also on the website. Okay, that was it. It's time to make room for the next session about healthcare management. So if you want to attend that one, the information is in this chat. And if not, I hope to see you in September. Bye.